Hello, welcome to your lecture for the ankle and lower leg. Today we will be covering injuries and signs and symptoms, and we'll also add in a few special tests for the ankle and the lower leg. And by lower leg, what I'm referring to is the tibia and the fibula. We will cover the knee in a separate online lecture. I think it's no secret, the cat's out of the bag. The ankle is by far my most favorite joint in the human body, and it really has to do with its central role in transferring force up the kinetic chain. And so we'll talk about the ankle joint and injuries, but we will not spend time in the anatomy unless we have to describe a specific injury. So please refer back to Professor Noakes' notes on the anatomy of the ankle and the lower limb. Our first stop is going to be in the way of just ankle injuries in general. So when we're thinking about the ankle joint, right, we kind of first have to do a little bit of a stop, right? So we're thinking ankle joint, and really what we're thinking is the talocrural joint of the ankle. So I'm going to adjust my ankle just a little bit here so that you guys can see that. So when we think about the ankle joint, there are really three, maybe four bones that comprise or make up the ankle joint. So you have the tibia proximally, you have its articulation or relationship with the talus. Do you guys see that? So this tibia sits proximally, and then that talus is going to sit just underneath that, right? You also have the tibia and its relationship to the fibula, right? In other words, there is a intimate relationship between the two bones. You can see how closely linked they are. They're actually touching, right? So we have the fibula and the tibia having a relationship and working together. You have the tibia's relationship with the talus, and then you also have the talus's relationship, right? So the talus's relationship with the actual calcaneus, right? So when I say ankle joint, I'll try to be very specific with which bones, which ligaments I'm talking about, because there certainly are several different joints within the ankle itself, all right? So with that said, the ankle joint in general, sprains particularly, are the most common injury in athletics. So let me say that again. Ankle sprains are one of the most common injuries in athletics. So if nothing else, this is an important lecture, right? Because it's going to be the injury that you're probably going to see the most often come into your clinic. So it becomes important to understand the signs and symptoms, to understand the mechanisms of injuries, and to figure out what you're going to do in terms of treatment plan and return to play for these particular patients. Okay, I'm going to give you a general etiology for ligamentous sprains about the ankle, but when I get to specific pathologies, we'll talk in more detail. So in terms of just generalized etiology, right? So we're talking here, most often to injure a ligament, you either have, okay, so lateral side here, you either have a sudden inversion moment, right? And if we have a sudden inversion moment where that foot is moving inward, then those lateral ligaments that support the ankle are now going to be injured, right? This is the case. This type of mechanism is typically happens in about 85% of the ankles that you'll see coming into your clinic. There are, in 15% of the cases, times where the foot moves outward, right, using an eversion mechanism, and then the medial ligaments get injured, right? And so why might you say, is there such a large difference between the number of ankle sprains that occur on the lateral side and the number of ankle sprains that occur on the medial side? And it has to do with, believe it or not, tibial, femoral anatomy or fibular anatomy, right? So let's look. We have lateral fibula, we have medial tibia, right? And so if we look at the bones just as they sit on the foot, and certainly you should look at them on the cadaver when you're in lab. So look at this. The fibula is a lot longer than its counterpart, the tibia, right? I don't know if you can see that in this angle, but let's go ahead and give you a close-up. When we look at the fibula, do you see how it extends? So it's longer than its tibial counterpart. What that means is there really isn't any room for the foot to move into an eversion mechanism. Hence the reason there are less eversion ankle sprains, because most often when that foot moves into an eversion moment, that fibula is going to stop it from going any further. Whereas if the foot moves into an inversion moment, right, so inward, it has more range of motion to move because that tibia is sitting up higher. So we have a higher risk of spraining the lateral ligaments because that foot can move more into inversion and stretch those ligaments, right? So that's why we see more lateral ankle sprains than we do medial ankle sprains in the field of athletic training or athletics. Okay, now let's get a little bit more specific. Your inversion ankle sprains most commonly result in injury to the lateral ligaments, right? And I think that makes sense. If the foot is going into inversion, right? So like if it's going inward, of course, everything on this lateral side is going to be stretched. Just as much as if that foot was going into eversion, right? We would expect those medial ligaments to get injured, okay? One concern with ankle sprains, regardless of if it's a inversion ankle sprain or an eversion ankle sprain, is that if the force is great enough, what you can actually have happen is a fracturing of the bone. So I think it'll play out better when I show you the next slide so you can actually see the anatomy of the ligaments. But essentially what happens is that patient is running cuts and inverts forcefully, and the ligament pulls off of its attachment site, right? So let's take a look at the next slide so you can see that a little bit. Right now, what we're talking about is a lateral ankle sprain. What does that mean? What that means is I'm walking or running. I immediately somehow maybe step in a hole. This has happened to many people that I know. I step in a hole. First thing happens is I plantar flex, foot goes down, invert, and my calcaneus right here moves inwardly, right? So we basically get this torquing of the foot so we can see how those lateral ligaments will get injured, right? So let's back up a little bit and say, okay, Dr. Cosby, you're saying dorsiflexion, plantar flexion. What is that again? So if I bring my foot up to the tibia, right, then that is dorsiflexion. Do that with me while you're watching. If I pull my foot down and point it, that is plantar flexion, right? If I point my toes inwards towards my midline, okay, that's going to be inversion. And then if I point my toes outwards away from the midline, then that is an eversion mechanism, right? So if we're thinking, how do we injure the lateral side of the ankle? Well, we have to stretch it, right? So we're going to plantar flex that foot. We're going to invert that foot. We're going to adduct or pull that calcaneus inwardly, and that will stretch all of the ligaments. So most often, you guys, the mechanism of injury is going to be plantar flexion and inversion, and that will cause a sprain to the lateral ligaments of the ankle. Okay, so what is a ligament? How do we define that, right? It's an anatomical structure that's responsible for holding two bones to each other, right? In other words, the ligament's job is to create stability about a joint, about two bones. Yes. And so in this image, what you're seeing here in this bottom right hand picture are the lateral ligaments of the ankle, right? And so the first ligament, which is the anterior talofibular ligament, is here. What you can see is that it has an attachment to the fibula, right? And then an attachment to the talus, right? So the two bones that it's holding together are the fibula distally and the talus, I guess, even more distally, right? So we have its attachment to the fibula and to the talus. So we can see how that's a ligament, right? There's two bones, the fibula and the talus, that it's holding intact. Then we have the calcaneal fibular ligament right here. And as the name implies, it's going to hold the calcaneus to the fibula. And then we have the posterior talofibular ligament, right? And that posterior talofibular ligament, guess what it's going to hold? The very posterior aspect of the talus to the fibula. So what we learn about anatomy, and I'm sure you're learning this in the anatomy class that you're currently taking, is that most anatomical structures are named based on what they either attach to or have an attachment with, right? And so anterior talofibular ligament, again, talus and fibula. Calcaneal fibular ligament means the calcaneus and the fibula are attached. And then the posterior talus and fibular are going to be attached to one another, right? These are the ligaments that are most often sprained in a lateral ankle sprain. What I will say is, in terms of ordering, what we typically will see is that the anterior talofibular ligament is the first injury to get, or the first ligament to get injured. And that really has to do with the fact that it is the weakest of the three ligaments in terms of its ability to withstand tensile forces. And so it's most often always injured in an ankle sprain or lateral ankle sprain injury, right? The second ligament to get injured is then the calcaneal fibular ligament. And the ligament of the three that is least often injured is the posterior posterior talofibular ligament. And it really has to do with the way that it's injured, right? In order to injure it, just think it sits posterior. See that? So it's like right here. Let's do it this way. This is the fibula. So it's going to sit right here and go right here. So it's going to have an attachment to that talus. So that means that we have to have, right? Think about that. To injure it, we have to have an anterior blow to the ankle. So most often, the posterior talofibular ligament, if it's injured, there was a massive amount of force. In other words, like enough force to probably cause an ankle dislocation. So it's just very rarely injured. For sure, you're going to get your ATFL or your anterior talofibular ligament, and then you certainly could also, along with that, get the calcaneal fibular ligament itself. So what I want to do now is give you tips of evaluating ankle sprains. So what we're looking at now is Ottawa ankle rules. And you guys are like, Ottawa, Canada? Yes. Okay. So what we know about Canada is Canada gives every person who is a legal resident there free healthcare, right? And so what was happening in Ottawa in particular is everyone that sprained their ankle went to the ER to get an x-ray, right? And they couldn't turn them away because that's a part of the healthcare system. So then Ottawa essentially got smart. They said, okay, let's look at the thousands of people that have come to visit us, and let's look at predictors of who would actually have a fracture. So they took the people that actually had the fractures and said, what were the common signs and symptoms that they had that would tell us exactly whether or not they have a fracture without having to do an x-ray, right? So they're using kind of predictive medicine to help us figure out who might actually have a fracture versus who has an ankle sprain. So I'm going to give this to you with the caveat that we don't always need to make the patient go to the ER. And if we're going to make the patient go to the ER, then what we should be using are Ottawa's rules. We should be using this right here because this is 90% accurate. In other words, if any of these is true, then you're 90% certain that the patient, got it, has a fracture. If none of these are true, then you're also 90% certain that the patient doesn't have a fracture. Does that make sense? Now, there's of course that like little 10% likelihood that they still could or could not, but using this in the clinical setting will help you right away. Of course, you have to know your anatomy a little bit. So the first step in Ottawa rules is bullet point number 1. Is there bone tenderness along the distal 6 centimeters of the posterior edge of the tibia? Okay, so let's look at that. Here's our tibia, right? Is there tenderness to palpation on this very posterior aspect of the tibia, right? So if we're looking at it from this perspective right here, yes. Do they have tenderness right here? Like, is there tenderness on this most posterior aspect of the tibia? Because then what you're thinking is an avulsion fracture, right? Remember, everth the ankle, maybe that ligament came off of it. The second bullet point applies to the lateral side. Do they have tenderness, right, on the most posterior distal portion of the fibula, right? The third bullet point really has to do with their ability to bear weight. Can they even walk? And if they can walk, for how long? Is it more than 4 steps? Is it less than 4 steps, right? If it's less than 4 steps, then you're probably suspecting that they have a fracture. Now, what I will say is there are people who just don't have good pain tolerance, right? So as a clinician, one of the things that you're going to have to start learning how to do is use your intuition. Is it really truly that they can't walk 4 steps, or is it they just need to suck it up and figure it out, right? You'll get good at that as you go along, right? Do they have tenderness here at the base of the 5th, right? Are you seeing that? So do they have tenderness here at the base of the 5th? Now, let's go back to that foot lecture. What pathology are we thinking here if they do have tenderness? Sweet. I hope you guys said Jones fracture, right? If you did, then that's why we touch here, right? We know that Jones fractures don't have great healing rates, so we want to get that patient in right away. And then the last area of tenderness is the navicular bone. So the question just becomes, do they have tenderness right at that navicular bone? If any of those 5 bullet points is a yes, then you're referring out to make sure that they don't have a fracture. If all of those bullet points are no, you can be certain that they don't have an ankle fracture. Okay, so this is a clinical tool that you should be using when an ankle sprain patient comes into your clinic to rule out a fracture. All right. In terms of management, there's so many different ways to manage ankle sprains. I've worked with, I'm going to say in my dissertation, over 150 ankle sprains. And in my clinical career, we won't even count. And so what I will say is the number one predictor of successful return to play without recurrent ankle sprain is protection. So that's why that P is highlighted. In other words, we want to protect that ligament. Put them in a walking boot for a couple of weeks and allow that ligament to shorten, right? In the past, that P didn't exist. And so we would rest them, we would ice them, we would compress them, we would elevate them, but we would forget to unload that ankle joint, right? If we don't unload the ankle joint, if we don't protect them, then that ligament is still being loaded as they walk. And guess what? That ligament heals in a lengthened position, which means it's not as good at providing stability to that particular ankle joint itself. Okay, so I give in my caveat about protecting your patient and being conservative in the treatment of ankle sprains, but there are other things that we should be doing as clinicians to certainly make sure that the ankle joint is strengthened and is ready for return to play. Increasing strength, not just at the lateral side of the ankle, but the muscles surrounding it. So we'll tibialis anterior, Tom, Dick, and Harry, which we've already talked about. Want to strengthen the gastrocs. So everything surrounding the ankle joint totally needs to be strengthened so that it can help provide stability to the ligament that was just injured and or compromised. You want to work on range of motion. So this ROM stands for range of motion or balance. And then you want to restore a normal gait, which I find is probably the hardest component to restore following an ankle injury. But you want to work on helping your patient get back to walking normally, because what they will learn to do is accommodate, right? Or adjust and or shift. Okay, so now we get our patient through our rehab program, and then how do we know that they're ready to return to play? What we want to do, I'm listing here a few things, but let me say this to you very clear. Your return to play for a patient is going to be very sport specific, right? 90-degree cuts, figure eights, jump landing, those are all great. But if I have a volleyball player, right, then I'm probably going to toss her a volleyball and have her dig for the volleyball to make sure that that ankle can withstand the lateral movement, right? If I have a basketball player, I'm probably going to have them do some crossovers, maybe a layup, maybe a few other defensive slides to make sure that they can actually function in their actual sports. So while this is a very general return to play screen, you certainly should also be using very sport specific return to play screening when you're actually ready for them to return to full participation. Okay, so here's an example of what swelling will look like if you're using the compression mechanism, right? You can see how it's pushed out the swelling, and now that swelling hopefully is moving a little bit more proximally. All right, so one of the questions that I always ask groups of students is about ankle braces, right? Or tape, because you're going to have the coach who walks into your clinic and says, hey, I want all of my athletes taped or braced, right? Not just the ones that have injured their ankles, but I want my entire team braced or taped, right? Because they're trying to prevent what we know happens, right? Which is 85% of inversion ankle sprains. Ankle injuries account for the most common type of injury you're going to see. So your coaches are smart, right? They're reading, they're seeing it in the news. So they're going to come to you and they're going to say, please tape all of my athletes. Well, what if you have a football team of 70? I don't know that I want to tape 140 ankles. I don't know that I want to brace 140 ankles, because that is an expense to your budget. So one of the things that I want to educate you guys on, and one of the things I've learned over the last couple of years, is that ankle braces and ankle tape are most effective for patients who have had a history of ankle sprain. And so in other words, if a patient comes into the clinic and they are completely healthy, they've never had an ankle sprain, there is no research to support the fact that tape or brace will prevent lateral ankle sprains, okay? However, if an athlete comes into your clinic and they say, yes, I sprained my ankle 10 times, there is definitely positive research to suggest that taping or bracing will prevent the next ankle injury. So for our healthy patients, what we want to do is train them proprioceptively and with balance. But what we don't want to do is tighten down that joint and teach it to react within a constraint, because that's the worst thing that we can do. In an injured joint or in a previously injured joint, we want to create, right, that constraint, because that joint is more mobile, it's more loose, so it's at a higher risk for injury. So I'm hoping that you're getting that. I mean, you're not going to push back on a coach in a clinical setting, but as you leave us, keep these things in mind because your budget is what gets taxed. And the reality is then you have all of these athletes coming in to get taped every single day. And while I love taping and I love the beauty of taping, certainly don't want to use resources when they're not needed. Okay. All right. In terms of rehab for ankle sprains, you'll have a whole course on this, but here are just some very basic things that you can do with them. Certainly doesn't encompass like joint mobilization or manual therapy, but this is a very basic rehab. So if nothing else, if you're in a clinical setting and your first patient on your first day is an ankle sprain, here are a few exercises that you could certainly throw at them that wouldn't cause any pain or cause any harm to your patient. Okay. All right. The next type of ankle sprain is an eversion ankle sprain. And as I alluded to before, quick review, the reason that we have less eversion ankle sprains is because that tibia on the medial side of the foot is shorter, right? And so that foot can't move into eversion as much because that tibia or that fibula is doing what? It's blocking it from moving, okay? So the tibia is shorter on the medial side and the fibula is longer. Therefore, the foot just can't get into eversion as much. So it accounts for about 15%. The mechanism of injury or the etiology for most eversion ankle sprains is going to be just an eversion mechanism, right? So here, foot moving outward, but it could also be a dorsiflexion eversion mechanism as well, which can cause an eversion ankle sprain. Yeah. On the opposite end of that spectrum, I do want to draw your attention to the fact that the medial ankle can also become injured in an inversion motion, but that wouldn't be a spraining, it would be more of a pinching, right? So if I go into inversion and it's maximum inversion, then you can imagine that maybe my medial ligaments might get pinched, but certainly not stretched, right? If we're stretching, we're thinking eversion is happening, that foot is moving away from the tibia itself. Okay. What we also know about foot posturing is that our pes planus are flat-footed individuals, right? Think about them. These people, flat-footed individuals, are at a higher risk for eversion ankle sprains because their foot is already flat and is already somewhat everted in nature. So they're at a higher risk for eversion ankle sprains, right? Okay, in terms of signs and symptoms, we'll just go across the board here. In terms of signs and symptoms, typically, depending on if it's lateral or medial, but that patient is typically going to be tender in the belly of the ligament. And again, we'll go back to Ottawa rules, right? If they're tender to palpation on those posterior borders of either the fibula or the tibia, then you're referring out to make sure there isn't a fracture. We also know about eversion ankle sprains when we compare them to lateral is that the patient has more pain on weight bearing with an eversion sprain. And the reason for that is, think here, right? So again, we're lateral here, and then let's turn it over. We're medial here. What we know about pronation is, remember, it's like this right here, right? So the foot is moving out into eversion, right? That arch is dropping down. And so automatically every time we bear weight, see that? Every time we bear weight, we're stretching the medial side of the foot. So that's why they're going to have more pain with an eversion ankle sprain during gait than they will with an eversion or inversion ankle sprain. All right. The next pathology that we're going to talk about is a syndesmotic sprain, or most people call it high ankle sprain. But for your exam, you will have to know it as syndesmotic ankle sprain. It is different than our eversion ankle sprain and inversion ankle sprain. Most often, the mechanism of injury is going to be dorsiflexion. So let me do it this way. Force dorsiflexion first, and then you essentially get the tibia moving inwardly and the foot moving outwardly. So you get a couple motions, right? You get like a ringing motion essentially, right? See that here, right? And so what we typically will see is that the lateral side of the foot doesn't get injured, but what happens is this joint right here, the tibiofibular joint, will get injured. So it's not a lateral ankle sprain, which occurs way low. It's a high ankle sprain. It's going to occur way up here. That's why it's called high. It's occurring above, ready? Above the ankle joint. Does that make sense, guys? I hope so. So this is the tibiofibular joint. Tibiofibular joint. It is held together by an anterior tibiofibular ligament. And so when we have a motion like this, ready? Dorsiflexion, eversion, it causes a widening of this joint, right? And a stretching of the ligament holding that joint together. So what are the signs and symptoms, and how are they different than traditional ankle sprains? With an eversion ankle sprain, you certainly have pain with weight bearing. But with a high ankle sprain, this patient will be in excruciating pain. So let's equate this. An eversion ankle sprain, they might have like a 5 out of 10. A high ankle sprain or a syndesmotic sprain, they're actually complaining of like an 8 or a 9 out of 10. And the reason for that is every time, just like with the eversion ankle sprain, every time they load that joint, right? Every time they load that joint, guess what's going to happen? Those two bones are going to move away from each other, right? So just imagine this, right? You're walking, you load, and those bones pull apart from each other every time you load, right? Because that talus is going to force them apart, right? So you get kind of it's called a diastasis, or a widening of the two bones away from each other. So we have to keep that in mind. With these ankle sprains, you guys, we are putting them in a walking boot. Why? Because we want to protect the integrity of that disto-tibio-fibular joint, okay? Most often, the pain is going to be more proximal. So think if you're trying to rule out a lateral ankle sprain versus a high ankle sprain. Lateral ankle sprains, the pain is located here, right? Whereas a syndesmotic ankle sprain is a little bit higher. So it's going to be way anterior lateral up here, right? Does that make sense, guys? Okay, good. In terms of management, like I said, you're probably going to put them in a boot. And what we know about these patients is they take longer to heal. And it has to do with the fact that the foot is always loading, always making contact with the ground. Therefore, that joint is always widening, right? And so they typically take anywhere from 6 to 8 weeks to heal themselves, whereas a traditional ankle sprain might take anywhere from 2 to 4 weeks. And so you can see there's an extended period of time. And with coaches, it's kind of hard, right? Because all they think is, oh, it's just an ankle sprain, but it's so much more than that, right? And you guys are seeing that. So let's look at this slide right here. It's so much more than that, right? So if we're looking at, do you see this? This is the tibia, orient yourself. This is the fibula. And so it's injury to this ligament here, right? We can imagine every time we're loading our foot, right? Every time we're loading our foot, just imagine these two bones moving away from each other, right? These two bones continually moving away from each other every time you load your foot. So we have to be really protective of this joint. And like I said, the best way to do that is truly through weight bearing. Okay. And so I really like this slide because to me, it allows you to see what the differences are between a high ankle sprain and a lateral ankle sprain, and really a medial ankle sprain. So let's look at this. If we're thinking high ankle sprain, right, the pain is going to be located here, and the injured party is the anterior tibiofibular ligament, right? Whereas if it's a lateral ankle sprain, the pain is going to be more distal, right? And more so directed on the foot or the lateral side of the limb. Do you guys see that? Okay, I'm hoping so, because you can misdiagnose a lateral or a high ankle sprain as a lateral ankle sprain, and that would be the worst thing that you could do, because you tape them up, let them go out, and next thing you know, you get a rupturing of that anterior tibiofibular ligament. So let's take a look at this slide right here, because one of the questions that I always get asked is like, well, how do we grade a ligamentous injury? Like, grade 1, is it a grade 2, is it a grade 3? And so this is a catch-all. Certainly a patient might present to you and look a little bit differently, but this is really, if we're talking about the standard right now in terms of grading ligamentous injuries in the ankle itself, then this is what we look at and regard. So first and foremost, this is an inversion ankle sprain, right? Foot's going inward, makes sense. So the lateral ligaments are being stretched. This is an eversion ankle sprain, which means what, you guys? Foot's going outward, right? And the medial ligaments are being stretched. And then you have a high ankle sprain, which means dorsiflexion moment. Dorsiflexion moment is occurring. You're getting some foot eversion, right? And so this part of the limb is being compromised or is injured. All right. So with that said, if it's a grade 1, so if it's a grade 1 injury, what we are saying is that when you touch them, they have very minimal tenderness to palpation. They have very little, if no swelling at all. They can function pretty well. And what we know is if we were to get an image, they would have very minuscule microscopic tears in the ligament, right? Am I making sense so far? So here's how I equate ligamentous tears. Think about this. Like when you're in a relationship, right? Usually like when you first start dating, like your handhold is pretty tight, right? So we go here. So think like a grade 1 would be like, you know how you like start loosening up your handhold at about like, 2 weeks of dating? That would be a grade 1. You're still tight, ligaments are still intact, but there's some really small, tiny tears occurring throughout the ligaments, right? This patient is pretty functional though, right? They don't have as much swelling. They don't have a lot of pain. They're able to weight bear. So what you're going to do is either tape that patient up, you're going to work on proprioception and balance and strength, and they should be good to go in a week or 2, right? It's when you get into the grade 2s and the grade 3s that you start to see limitations in the patient's functions, and you also start to see increases in their signs and symptoms. So with a grade 2, they're going to have more tenderness. So we're talking that 5 to 6 on a scale of 10. They're going to have swelling now that is present and visible. And the 2 things that we didn't have with the grade 1, they're going to have lack of range of motion, the inability to move typically into dorsiflexion and plantar flexion moments. And they are also going to have instability about the ankle joint itself. Okay. All right. For impairment, it's going to be more moderate. So in other words, they may not be able to walk without a limp. Does that make sense? They may not be able to walk without pain. Yes. They may not be able to participate in sports. And what we know about this particular ankle joint is that there are absolutely tears, not microscopic, large tears in a ligament and or 2. So let's go back to this hand holding, right? Where it's like grade 1's there. Grade 2 would be like here. You guys seeing that? Grade 2. And then a grade 3, which is the last, you see it there, is a complete rupturing. So we just broke up, right? I'm no longer holding your hand. I don't want to hold your hand, right? Those ligaments are no longer intact, right? So a grade 3 is they're going to have swelling. They're going to have ecchymosis. They're going to have lots of pain to touch. They're going to have deformity where that ligament should be, but now it's ruptured, so it's no longer there. And so their impairment is going to be severe. In other words, they might not even be functional. They might not be able to bear weight. Does that make sense? And so in this particular case, we're gonna have to immobilize them first, put them in a walking boot, allow that ligament to heal itself. And in some cases, what we see is if it's a complete rupture, that patient might actually have to go through some type of surgical intervention to repair that ligament, right? So what you're going to see most often in the clinical setting are your grade 1s and your grade 2s. And really what changes in a grade 1 and a grade 2 is the return to play and the way in which you would treat your patient. In other words, a grade 1, we might tape them and let them go back into participation. Grade 2, we're pulling them from participation, we're evaluating them, and we're determining how long they're going to be out before they can actually return. And then the grade 3s, I think they're extremely rare, but they certainly happen. If we have a grade 3, you're looking at 8 to 12 weeks, potentially even longer than that if surgical intervention is required. So I hope this helps you kind of at least get a gauge of what the grading system looks like. I think one of the things to also keep in mind is that laxity, looseness of the joint is going to go up as the grades of spraying go up as well. In other words, they're going to have increased looseness from grade 1, 2, and 3. All right, moving into more traumatic ankle injuries. I never thought I would see one of these in my clinical career, but I've seen 2. So I think it's important, especially those of you that will be working football, to at least have an understanding that there is the potential for you to actually have or a patient who suffers from a fracture or a dislocation. And so the etiology is traumatic, right? They get kicked, they're jumping, and they're bone fractures, but it's a traumatic incident. Most often it is not traumatic and it is not chronic, right? What are the signs and symptoms? Well, the obvious one is going to be lots of swelling, but clearly the deformity, right? So let's look here. The deformity is what you're going to see, right? We obviously know that his foot shouldn't be turned this way, right? And so in essence, do we have a dislocated ankle? Do we have a dislocated knee? We have a dislocated something because his leg is turned the wrong way. Can you guys see that? So that would be an obvious clinical sign. In terms of management for these particular patients, we are going to control bleeding if in fact the bone has protruded through the skin. We're going to splint them, and then we are literally going to refer them out. If it's a dislocation and there's no neural compromise, we've seen patients return within 6 to 8 weeks. But if there's fracture associated with it, then it certainly could take a lot longer to return that patient to play. The big deal is with a fracture and dislocation, we're referring out. Dislocations in particular are medical emergencies, so we want to refer out as soon as possible. You can look at this image here and let's see if you guys are good. So which anatomical structure is this right here? Okay, I'm glad you all said the talus. I'm going to assume you all said the talus, right? And then let's go ahead and orient ourselves. We know that this bone is longer. So which bone is this? Good. So the fibula. So this is the lateral side. And then we have pieces of our tibia, right? So we've got a few different fractures. We got a fracture of the distal fibula. We have a fracture of the distal tibia. Can you guys see that? Awesome. Okay, so we're just going to look at different types of fractures that can happen. So this is a distal tibiofibular fracture. See it? Not necessarily traumatic, but certainly cutting and force can cause a fracture, specifically in patients who have stress fractures already or presiding stress fractures. One of the most common types of fractures that I've seen in ankle joints is baseball. The inability to slide into the base correctly can lead to this right here. And then last but definitely not least, on the fracture end, we can certainly have a fracture, a direct fracture to the bigger bones, the tibia and the fibula. So we're talking the shaft, right, of that bone, not the distal portion, but the shaft of that bone. Most often that's going to be as a result of a direct blow, but it could also be that that patient had a stress fracture just sitting there and enough force to cause it to completely break. What we know about fractures is they occur, remember I said that in the point where the bone is changing its shape. So for the fibula, look here, most often the fracture is going to occur to about the middle third of it because the bone is changing its shape right about here, right? What we know about tibial fractures is that the fractures typically occur right in this space here, or the lower 1/3. And again, that's where the bone is changing its shape, right? So just think, wherever a bone is changing its shape, that's where its weakest point is. In terms of signs and symptoms, pain, swelling, soft tissue injury. You're also going to see lots of ecchymosis or bleeding underneath the skin. So it's a referral, right? We're going to splint that and we're going to refer out, right? But what if, I've shown things that are fractures that are so obvious. What if the fractures aren't so obvious? So what we're going to do is look at a few clinical special tests that we can all use in the clinical setting to help us rule in or rule out a fracture. The first one is called the compression test. So I'll let it play. So this is the compression test. You're going to take both hands and squeeze on the tibia and fibula. And if the patient complains of pain, then you're going to refer that patient out, right? Because again, some fractures might not be as obvious. That's going to be your compression test. The next test that you can use is the percussion test. So the percussion test is going to be right here. You're going to dorsiflex that foot. Do you see the dorsiflexion of the foot? And you're going to pound or bang on that calcaneus. You can imagine that that's sending vibratory forces up the tibia or the fibula. So that patient's going to complain of pain. So if you suspect a fracture of the tibia or fibula, these are two quick clinical tests that you can use to help you assess whether or not that patient has a fracture. All right, let's go ahead and look at Achilles tendon ruptures. And so this is kind of graphic. So if you don't like graphic images, please turn away at this point in the lecture. So we have an Achilles tendon rupture. What I will say is we've talked about Achilles tendinopathies in our foot PowerPoint, right? So what I'm going to say is if a patient has an Achilles tendon rupture, it was most often because they had an Achilles tendinopathy that you as a clinician did not care for. Now, there are some just random cases where the patient just literally happens to rupture, but most often Achilles tendon ruptures occur because there was already an inflammatory response occurring within the Achilles tendon itself. So in terms of mechanism of injury, it occurs with a sudden stop and go. So like I stop and then I cut to go and then boom, there's a pop. It typically happens in those that are at least 30 years of age, but certainly could happen to anyone, right? I'm just giving you specific categories. And then what we know about this is the risk for Achilles tendon rupture increases if there's an inflammatory response. So what I alluded to earlier on. So what are the signs and symptoms? The first sign and symptom, they will literally complain that they felt a sudden snap. They will tell you, if you ask them, that it felt like someone kicked me, but there was no one around, right? So that's kind of like the number one sign and symptom for an Achilles tendon rupture. What you will feel is, number one, kind of like a gap or a space where that Achilles tendon used to be, and it's no longer there because it's probably rolled away. And it's ruptured, right? And so what we use in the clinical setting is a test called Thompson's test. So I'll show it here. And so with Thompson's test, this is a complete Achilles tendon rupture. When you squeeze that gastroc, the foot should move into plantar flexion like it does here. See that? But in this particular patient, on the other side, because the Achilles tendon is not intact, ready? When we squeeze that gastroc, the foot will not move. So a positive Thompson's would be squeezing those gastrocs and the foot not moving into plantar flexion. Okay. All right. So how do we manage an Achilles tendon rupture? It's pretty straightforward. Those patients are going right into surgery, and they're going to have surgical repair, and then we get them back in our clinic, and then we have to do rehabilitation with them. The Achilles tendon is like the sister to an ACL rupture. In some cases, it takes longer for a patient to recover from an Achilles tendon rupture surgical repair than it does for them to recover from an ACL repair. And that's because of the amount of load that the ankle has on it, because it receives the forces from the ground. But we're looking at about 4 to 6 months that patient will be in your clinic doing rehab with you. In terms of Achilles tendinopathy, if you should choose maybe not to do the non-operative route, maybe they just have a partial tear and they're not ready to do the surgery, then you're just going to ice it to reduce. Does that make sense? To reduce the swelling. Going to wrap it and protect it, and probably put it in a cast for about 6 weeks to make sure that those fibers are allowed to heal themselves, so that they're not at risk for a rupture, right? So again, I'll say that again. You can have a partial tear of an Achilles tendon. If that's the case, we're going to treat that non-operatively. We're going to do that very conservatively with non-weight bearing, usually typically casting or a walking boot. Injury that can happen to the lower limb is a gastroc strain. They're actually pretty rare. You would think that they happen more often, but the reality is, unless the patient is inflexible, most often gastroc strains do not happen very often. Mechanism of injury for a gastroc strain is most often going to be hyperdorsiflexion moment. So in other words, you're doing what to that gastroc? You're stretching it, right? Signs and symptoms are going to depend on the grade. So go back to that sprain table and apply it the same way here to the strain table. So a grade 1 would be like a stretching and maybe microscopic tears of the gastroc, right? Patient's pretty functional, very little swelling, right? A grade 2, you're actually going to have some tearing, but the muscle is still intact. So that patient's going to present with more swelling, probably some ecchymosis or redness, right? Tenderness to palpation, certainly limitations in plantar flexion, range of motion, and a weakness there. And then a grade 3 would be a complete rupture of the gastroc, right? And so they would have extreme weakness in plantar flexion. But what I will say about gastroc strains is there's a third muscle that is missing on this slide. So it is called the triceps surae muscle group. And what we know about the triceps surae is that there's 3 muscles. There's the medial gastroc, there's a lateral gastroc, and then what's the deeper muscle? Good, it's the soleus, right? So even though the patient has a ruptured, you ready for this, gastroc, they could certainly still be able to plantar flex and function because the soleus is typically still intact, right? So those are the 3 grades. Again, very rare, but still certainly should be able to assess it. What you're looking for is limitations in strength for plantar flexion, range of motion. Have the patient do a toe raise, right? And see if they can do it. If they can't bear weight, have them press, ready? Have them, so we're here, patient's on the table. This is the plantar aspect of the foot. Have them press on your hand, right? You provide resistance and they're trying to push you down to see what their strength is like in the clinical setting. Our last pathology or group of pathologies is what we consider more chronic in the lower limb. So now we're progressing to our chronic and overuse pathologies in the lower limb. This is probably the second most common lower limb injury minus the ankle. It's medial tibial stress syndrome, or what you all might know as shin splints, but please don't call them that in my class. Okay. In terms of etiology, it's a lot of different things. It could be overuse, so too much, too soon, too fast. Could be lack of changing of shoes with lots of mileage. It could be that the patient is a hyperpronator. So what we know about Tom, Dick, and Harry, right, is, remember, this is medial side, so they're going to be coming off of the tibia, right? So Tom, Dick, and Harry attached to the navicular, to the first ray, right? Just giving you concept, or come around and wrap around to the plantar aspect of the foot. What we know is that if the foot is plantar flex, remember, and everted, so here we're going to be stretching Tom, Dick, and Harry. In particular, the tibialis posterior muscle has a direct attachment. You can kind of see it here, has a direct attachment to the tibia, right? And so if it gets stretched, it will irritate the tibia and cause the signs and symptoms associated with shin splints or medial tibial stress syndrome. So let's look at progression, because what we know about medial tibial stress syndrome or shin splints is that it can progress. It can progress into tibial stress fracture. So we have, anatomically, we have the skin, and then deep to the skin, we have the muscle, and then deep to the muscle, we have what's called the periosteum. And then deep to the periosteum, we have the bone. This periosteal layer is red for a reason. It literally wraps around the bone, right? All bone. It wraps around the bone, and it's its protective layer, essentially. I like to think of it like putting saran wrap on my arm. So it's really tight. So in general, the progression is we have a tendinitis of tibialis posterior, right? So just think about this. We have a tendinitis or an inflammatory response that's occurring to the tibialis posterior, which is this muscle. Either that patient continues to load, to pound, to not rest, right? And essentially that inflammatory response then drives deep down into the periosteum. And if it gets under that periosteum, then the next thing that happens is that swelling, right, starts to compress onto the bone, and it causes the bone to go into a stress fractured state. So the ideal is that we'll catch it here, right, when it's in its tendinitis stage, in the medial tibial stress syndrome stage. This is one of the injuries that I treat very conservatively, because it can certainly progress into a stress fracture, right? And that's not what we want for our patients, right? We want them to have medial tibial stress syndrome and not develop into a stress fracture, because stress fractures take anywhere from 8 to 12 weeks to heal themselves, okay? So pathology, number one, it's inflammation of the tibialis posterior. Most often, certainly flexor digitorum longus or flexor hallucis longus can be injured as well, but most often, in 90% of the cases, it's the tibialis posterior that's responsible for the development of medial tibial stress syndrome, okay? You have this inflammatory response like I talked about, most often as a result of like a hyperpronated foot just stretching that tibialis posterior so much, right? Okay, and so then our next slide progresses to what are the signs and symptoms. So what we know about patients with medial tibial stress syndrome is that the bulk of them present to us with pain in that lower 1/3 of the tibia. Now, go back a few slides. Where did I say the most common fractured site for the tibia was? You got it. It's right here, right? So common site for medial tibial stress syndrome. Would it make sense that it's the common site for fractures? Absolutely, right? So they're going to have pain or tenderness to palpation most often in that lower 1/3 portion of the tibia. Certainly will have some swelling, but it isn't always going to be the case that with medial tibial stress syndrome that there'll be swelling. So please take that with a grain of salt. Pain for sure, right? And then the other thing that we know about these patients is that when we resist, ready? Inversion and plantar flexion, ready? So plantar flexion and inversion, they have pain. What does tibialis posterior do concentrically to the foot? Good. You're learning, right? The tibialis posterior does what? It does inversion and plantar flexion. So would it make sense that they have pain with that motion? Yes, because again, that tibialis posterior is attaching to that tibia, right? And so as a result, guess what's happening? As it works concentrically, it's also being loaded and more inflamed. Okay, guys? So how do we fix medial tibial stress syndrome? Personally, I would say rest, but your coaches aren't going to like that. So we have to look at foot posture. We have to figure out, do they need orthotic therapy? We could tape the foot, which refer back to the arch tape job, because that is the tape job that you would do. And this week, we're going to learn the tibial tape job to help with shin splints. So we can tape, certainly. And then in the event that a patient is in periostitis, right? So if I go back to this slide, in the event that they're here, then you want to boot them because the next progression would be a tibial stress fracture. Okay, guys? So treat them conservatively so you don't have stress fractures on your hand. All right. Well, I guess that makes sense to segue into stress fractures of the tibia or fibula. Most common stress fracture is going to be to the tibia because it is a weight-bearing bone. The fibula is not a weight-bearing bone, so stress fractures are more rare, but they certainly do happen. We know that anything that's a stress fracture is as a result of overuse, right? Most often we see tibial stress fractures in runners and jump landing sports. So most often that's going to be your basketballs, both basketballs, and that's going to be your volleyballs, right? Certainly, and running. Certainly can have any of those sports who will present with a tibial stress fracture. So in terms of the signs and symptoms for a stress fracture, I'm going to point you to here, and I'm going to say it's a hop test, which we'll do in class, and it's night pain. So again, that night pain goes back to not just, oh, it hurts at night. It wakes me up at night. I cannot sleep. You want to refer out just to make sure, number one, that they don't have the stress fracture, but number two, that anything else isn't going on. And I guess last but not least, in terms of management, what we want to do is reduce activity. You guys, I am so conservative with tibial stress fractures. So it says 2 to 6 weeks, but I've held athletes out for 8 to 12 weeks. In particular, my female cross-country runners, because there's typically some type of disordered eating associated with that as well. So it's not only just waiting for the injury to heal themselves, it's also looking at dietary issues, weight issues, etc. Okay, so there's a bigger picture to this process. If your patient refuses to go non-weight bearing, then either you put them on crutches or a walking boot just to protect the tibia from the load transference that happens at that weight bearing bone. And then the biggest thing on this slide that I'm going to point to is this right here. That once you decide they're ready to return to play, they just can't go right back into it. There actually has to be a progression. What we know about bones is that you have to slowly increase the demand that's being placed on it, right? So if I take a patient who's been immobilized, who hasn't been loading, and I let them go back to full participation, what do you think is going to happen? Right, they're going to be back in our clinic with another tibial stress fracture. So what I would recommend is, number one, starting them out with something soft in terms of foundation, right? So first start them with running, jumping on grass, because that has a little bit of give and doesn't cause as much load on the tibia. Then progress to maybe a treadmill. You can use underwater treadmills, which are anti-gravity and don't cause a lot of load on the tibia. Then to the track, which is soft, dirt, and then finally to asphalt or concrete. So you can see how there's a progression, right? And that progression happens over days and weeks and sometimes months, depending on your particular patient. All right. Our last pathology for the day is tibial compartment syndrome, or we'll call it compartment syndrome. What I do know about your anatomy class is you guys spend a whole bunch of time in the compartments of the lower limb, but I'm just going to review really quick. You have the lateral compartment, which is responsible for concentrically causing eversion of the foot and houses the peroneus longus and the peroneus brevis, right? Okay, and then you have the anterior compartment, which is mainly responsible for toe extension and dorsiflexion of the ankle joint, right, guys? It's going to house your extensor muscles and the tibialis anterior muscle, and then you have the muscles of the posterior compartment, right? The deep posterior compartment is going to house Tom, Dick, and Harry, and then your superficial compartment is going to house the triceps serrae muscle group, right? And so why is knowing that important? Because the next pathology that we're going to talk about plagues the anterior compartment. So what am I saying to you? That's your extensors and that's your dorsiflexor group, right? So this pathology is called anterior compartment syndrome. And it typically occurs as a result of an increased amount of swelling in the anterior compartment, right? And so when that happens, what happens next is exactly what you're going to say to me, is that if there's a lot of swelling in that compartment, that swelling can't be contained. In other words, the tissue just doesn't expand enough. And so what happens is the swelling starts to compress on the neural structure. So which artery and nerve supplies the anterior compartment? Good. So did you say deep fibular, deep peroneal nerve? Because if you did, you would be right. Okay. So etiology wise, it's usually a direct blow to that anterior compartment. And when we have class, I'll show you where the anterior compartment is. But you can imagine this is tibia, right? So a direct blow right to the tibia, which causes an increase in swelling. And then that swelling will compress on that deep fibular, deep peroneal nerve. And so then you will get neural signs and symptoms which are associated with that, right? So the neural signs and symptoms that your patient will present with are right here. Number one, they're going to have pain to touch, right? They're also going to complain of numbness and tingling down the chain because why? Because that swelling is compressing on what? The deep peroneal nerve, which means if it's being compromised, so is everything below it. Yeah. They may have pale if they are Caucasian or lighter skinned, or ashen skin if they are of dark complexion, right? And then if we check a pulse, right? So if we go down here and we check that dorsal pedal pulse, they won't have one, right? Because there's so much pressure on that compartment that blood flow isn't driving distally, right? So this, my friends, is a medical emergency if that is absolutely the case. And what we do when we get there, when they get to the ER, is the patient will go through a pressure check where a needle is embedded in the anterior compartment and they look at the pressures. And if the side-by-side differences is more than 10, then they go ahead and they do what's called a fasciotomy or a fasciectomy, which means they're cutting the fascia of the anterior compartment to allow that swelling to move out of the area. So these are the very basic injuries of the lower limb. I hope you've learned a lot and will feel more confident in assessing patients who walk into your clinic with these specific pathologies. Look forward to seeing you in class.